So I know you've all introduced yourself everywhere, but it helps me to know what your background is. So maybe first name and what your role is on the multidisciplinary care team and where you're from. So we can start right here.
Okay, yeah, so I'm Shane Grimna again, so I'm the MSL at AbbVie Oncology.
He's introducing the, your what? Your...
I'm the MSL at AbbVie Oncology.
Okay. Yeah.
Rachel, MD.
From where?
Justin Lebanon, I'm a clinical development specialist for the PEDS blood and marrow transplant and hematology oncology group for Masonic Children's.
Oh, okay.
Tom Maley, hematologist, oncologist, Knoxville, East Tennessee.
Okay. Craig, I know.
Catherine Norman, I used to work at the U in medical oncology, but I'm at Frauenschuh in St. Louis Park.
Okay.
Nurse.
Alice Senko, I'm a MSL at Celgene currently, but in my old life, I was a transplant coordinator at Roswell Park, so I worked here. So I was here
Right.
20 years ago.
Oh, wow.
The initial
Yeah.
discovery.
I'm Shweta Chaudhary. I'm a resident in pathology at Ohio State University.
Oh, a pathologist. That's what I needed. All right. Enough with the rest of you. I just got to know if I've got a pathologist in the crowd.
And I'm Sarah, and I'm an oncology nurse at HCA.
Okay, great. So our session here is about minimal residual disease, first clinical remission, and really what is the definition of remission in this day and age, and then the role of transplantation. The majority of patients, unfortunately, with AML are destined to relapse. Okay, it's just unfortunate thing to say, but it's true. And that, as we talked about earlier today, that age in of itself is a poor prognostic feature. Patients that are older are more likely to relapse. And you've already been, I know that by now, because this is the last group, that therapeutic options for relapsed AML can be tough. We're getting new ones all the time, but I think the real key point is allogeneic transplantation is a curative option for patients with AML. And for those of you who are non-transplanters, that when we think about transplantation, historically we had standard or myeloablative conditioning regimens with a huge doses of chemotherapy and radiation to try to ablate the marrow. And then with those new cells coming in, hope that we would have a graft versus leukemia effect, help reduce relapse. For older patients with our reduced intensity regimens where we don't ablate the marrow, we're really relying on that graft versus leukemia effect to try to help reduce relapse. And so we know that it's curative. I did my first transplant in 1984. And at that time, for patients with AML, we typically went to a transplantation in third remission. And most patients didn't get to third remission because the risk of dying from a transplant was pretty high. Now we do know that outcomes with transplantation are much better if you get that patient to transplantation in first clinical remission. Outcomes are pretty decent in second clinical remission, but it's probably a selected group because those are the patients that actually got into remission, right? So think about it, and that's why we drove home the point this morning that to do a HLA typing for all of your AML patients at time of diagnosis, because in the back of your mind, even the favorable risk patients, there's going to be a significant risk of relapse, and then they will need to get on to a salvage therapy and transplantation. So if you just take all groups, and of course there's wide variability, but typically you could say that for a patient in first clinical remission, that of all comers, that we can reduce the relapse rate by about half. And so we really look at all of our patients in CR1 who we feel have a significant risk of relapse for transplantation. And there are many studies, including meta-analyses, that have shown that there's a better disease-free survival and overall survival of patients that are the highest risk or adverse risk, the intermediate risk. And yes, you can take a patient with favorable risk to transplantation and reduce their risk of relapse, but it's the balance of treatment-related mortality. So this is our case for here. We have a 59-year-old gentleman who's been tired and having some more shortness of breath over the past few weeks, but otherwise a pretty unremarkable past medical history, really not taking any medication. Review systems is pretty negative. Comes in the door. Little tachycardia, but performance status, when you review those features, is really good. And the only things that you see on examination is some conjunctival and palmar pallor, which is making you think of some anemia, and some lower extremity petechiae, which are making you think of thrombocytopenia. But otherwise, a pretty negative examination. So Craig, you want to walk us through the CBC?
All right. So
I pick on my friends.
yeah, that's good. So the white blood cell count itself is not that remarkable, although when you start to look at what at least what we know from the differential, the absolute neutrophil count is low. And so along with that, the patient's also anemic and thrombocytopenic, and so there's pancytopenia. When you see pancytopenia, not just looking at the numbers, but looking at the blood smear is always a good way to get some ideas about what might be causing that. And so some of the features that they describe, the dysplastic neutrophils, as well as mononuclear cells with a high nuclear to cytoplasmic or NC ratio, make you worried about some type of myeloid neoplasm, and with the dysplasia, either MDS or perhaps with these cells with high NC ratio and loose chromatin, which could represent blasts, perhaps an acute myeloid leukemia.
So kidney function is pretty good, liver functions are right, not having DIC. And so you're suspecting there may be a leukemic process, particularly after you look at the smear and you're ordering an aspirate and biopsy. And you've sent off some flows we talked about this morning, that often peripheral blood flow. You can get a sense of that as you're doing your aspirate and biopsy. So this marrow is hypercellular. There's both neutrophil and megakaryocytic dysplasia, and 45% myeloid blasts on the aspirate. The flow cytometry shows markers for myeloid markers, consistent with AML. It's negative for lymphoid markers. Metaphase of 20 had 46XY, so normal male karyotype. And you have your initial molecular genetic studies back. And there's no NPM1, FLT3, or CEBPA mutations. So by the 2016 WHO classification, World Health Organization, this would be classified as AML with myelodysplastic related changes. And I think the key point that we want to take you to take out of this is that there's no history of MDS in this patient and looking at previous blood work, but the dysplasia is a poor prognostic feature along with the normal karyotype, as compared with a normal karyotype without having that dysplasia. So this is a category of AML with myelodysplastic related changes. So we've also been driving home the point of clinical trial, and this patient was enrolled in a phase 3 trial and randomized to cytarabine and high-dose daunorubicin, but bummer, had some problems. The course was complicated. It's got febrile neutropenia, and you think that your patient has fungal pneumonia. So day 14, Marrow was performed and revealed a markedly hypocellular chemotherapy-ablated marrow, and you started growth factor. So would any of you have given growth factor in this patient or not? What's your practice at your institutions? Can you help me, or what your usual practice is? Anyone? Okay, Craig, would you have given growth factor to this patient? You guys, you got to speak up a little bit. You don't, huh? Would you have given growth factor?
Yes.
Why?
It depends on the situation. We usually tend to give it.
Because of you given all your patients, or what do you do? What would you make you drive to give growth factor?
The degree of neutropenia, height of the fever, generally speaking.
Okay.
So I would say maybe 65%
Of your patients, you'll end up using growth factor. Craig, what are you currently doing at the U?
Well, so I'll say,
You did a study, didn't you?
Even in my relatively, well, I wouldn't, it's getting to be longer tenure at the university now. We've sort of waffled back and forth somewhat about the use of growth factor in induction therapy for AML. And the current, for the last year and a half or so, we've stopped routinely giving people growth factor as sort of a preventive measure. There's been several studies, and actually a fairly large meta-analysis and actually a Cochrane review as to the use, the role of growth factor for AML induction therapy, that while there is some benefit in the incidence of, I can't remember if it's the incidence of neutropenic fever, the bottom line is that there's no major improvement in outcomes with preventive use of growth factor. so our practice is not to give everybody any kind of growth factor, although there are settings when people have active infections, and we'll use it on a case-by-case basis, but we've shifted away from, and it's quite expensive as well, and so we've shifted away from using it.
We don't use it usually.
Yeah. So the next point that I'll bring up related to growth factor is skipping ahead to this day 28 marrow, there were 2% blasts. Do you worry that growth factor will cause leukemia relapse in your patients or
So
not?
Part of the larger meta-analyses showed that there is no demonstrable increase in the risk of induction failure or relapse with the use of growth factor. And so it doesn't appear, while it's not particularly effective, it doesn't seem to be detrimental.
But it can make a bone marrow a little difficult. So I was going to ask our pathologist friend. So make sure that you talk with your pathologist. You want to talk about the growth factor and what the effect might be on a marrow when you're interpreting it?
Yeah, I mean the cells, with the growth factor, you see more granularity within the cytoplasm of the cells, and they start looking a little weird. So I mean, and you have to look into the history if there is a GCSF therapy given, and then in the comment section we always mention that the patient was given GCSF. So like we are interpreting it like that, but like then we talk with the hematopathologist, like the hematologist should know like the GCSF effect was on the cells. So cells are looking a little different from what they look without GCSF.
Because it could be hard to know whether or not regenerating marrow or growth factor effect. So that's one point, but I also want now to tell you your next generation sequencing came back, all right? And this was performed on the initial diagnostic marrow. And now you know that this patient has mutations in ASXL1 and SRSF2. So we're going to talk about that in a minute. And luckily, on day 28, the blood counts are recovering. In order to say that a patient's in a morphologic and in a clinical remission, first remission, that you need to have count recovery as well. And so that's why we told you that the neutrophil count's now above 1,000, the platelet count's above 100,000. Marrow looks pretty good, and there's 2% blast, and the patient wants to know, am I in remission? Okay, do I got any bad cells in my marrow? Because they know the results are back. You told them the results were going to be back the next day, right? They want to know. So here we go. So these are the things we're going to talk about. How would you risk stratify this patient's disease? How would you treat this patient if they're in first remission? What is MRD? And did you test for it along with these marrows that you just have completed when you think this patient's in first remission? And do the results, if the patient does have MRD, does it matter? You're planning to go to transplantation for this patient, but is there any pause about MRD status? So by the 2010 ELN classification, this patient would have fallen into an intermediate 1 category. This patient had normal cytogenetics, normal karyotype, and had wild type NPM1 and did not have a FLT3 mutation. This is a really large study that was published in JCO in 2011. And I think one of the take-home points here is that only about a quarter of your patients are going to fall into the favorable risk category. So 3/4 of your patients have either intermediate or adverse risk features for which we think that transplantation is probably the optimal approach for those patients if they are a transplant candidate. And this also comes back to the point about age. The same publication for an intermediate 1 patient, if you looked at the probability of relapse for an 18 to 60-year-old patient, was 65% at 3 years. But if you were an older patient, it just went up to 75%. So age is a poor prognostic feature. But now we have the update, right? You heard about that throughout the day. And the 2017 update includes additional molecular markers that we're now aware of. And so next generation sequencing came back, and this patient has a mutated ASXL1. So this patient no longer has intermediate risk disease. You're going to need to explain to this patient that some additional things came back, that you have some more information about this patient's disease, and they actually have really the highest risk category for relapse. They're an adverse risk patient. So what are these mutations, and why is it so bad? So that this slide shows you some data from a couple of publications the Mesler group, which looked at ASXL1, and then the Papanula group that was published in the New England Journal of Medicine took that a little bit further and looked at the impact by adding the molecular test of SRSF2. So on the left-hand panel, if you look at overall survival, that if you have the mutation, and that is the dashed line, that your overall survival is significantly less than if you do not have that mutation. You take a look at the right-hand panel, I'm just going to draw your attention to the blue line. The blue line starts at 100% overall survival at diagnosis, and you can see that it falls to 0 at 4 years. This was standard therapy. So that if you have both of these mutations mutated, as opposed to one or the other, you have worse outcome. So it's bad. So, which brings us to, based on the best available data, this patient would likely benefit from allogeneic transplantation in first remission. And this is the data, if you'd classified this patient by your initial testing that you knew that their overall survival without a transplant, this patient's 59, would have had an overall survival estimated just a little bit over a year as opposed to not being reached if an allogeneic transplantation was performed, and a similar positive impact on outcomes with relapse-free survival. So now we're going to talk about MRD assessment, and I think the thing to keep in mind is that how we first started thinking about minimal residual disease was in pediatric ALL. And that was based on prospective trials because most children are enrolled on Children's Oncology Group or COG protocols. So prospectively, we understand a little bit more about MRD. We really don't have any guidelines for MRD assessment or when to do it or exactly what it means in prospective trials for AML. So the data I'm going to be showing you is primarily based on retrospective analyses. So in this patient, by flow cytometry, remember with that patient had 2% blast in their bone marrow? That would still fall into the morphologic classification, being in a first clinical remission of less than 5% blast morphologically and of having normal peripheral blood counts, right? So you told this patient you had really good news. Didn't you? Yeah. But you tempered it because you wanted to leave yourself an out.
Been burned too many times.
Then burn, yeah, because then you get additional data back. And so this patient by flow, and it's really important, we talked about earlier in the tumor board, that incredibly helpful if you have the diagnostic testing done at the same center as the follow-up data, because testing varies by center, by how many panel of flow, your ability to detect. And this patient, what we're proposing to you is this patient unfortunately does have minimal residual disease by flow. So it has some blasts still there. And what does that mean? So now this is retrospective analysis, but this is from the Seattle group. And they are the ones that really push forward in terms of TIN flow cytometry. And this is all based on MRD assessment of marrow or peripheral blood. And to just tell you what this shows is that red is minimal residual disease, okay? And the blue line is not. And the left upper is, this is the cumulative incidence of relapse here. So red line, much higher relapse if you have minimal residual disease. Panel B is whether or not you have a complication during induction therapy, and that didn't matter, or your outcomes. Non-relapse mortality wasn't part of that. But overall survival, relapse, relapse-free survival, having minimal residual disease is worse than if you don't. This is molecular-based MRD assessment in peripheral blood. And this is from the UK National Cancer Research Institute AML Working Group. And they did quantitative PCR. And again, MRD positivity is in red. So in the left-hand panel is survival. So your chances of surviving were significantly worse if you had MRD at time of first remission. On the right-hand panel, it shows you that your chances of relapsing are 86% at 5 years compared with 34% if you had MRD negativity. This then looked to see whether or not this was independent of some of these molecular mutations that we're aware of. So then they divided this and looked at patients with FLT3 ITD, that's on the right-hand panel, or if they didn't have FLT3 ITD, And the take-home message is that independent of FLT3 ITD, if you have minimal disease positivity, it's bad. Okay? They also looked at a very common mutation known as DNMT3A. And again, independent of whether or not that, if your patient does or does not have that mutation, is that MRD positivity is saying that you're going to have a much higher chance of relapsing. And then this is the WASH-U group. And you may have heard of Timothy Lay's group, did next generation sequencing for patients with AML. And how they define minimal residual disease is by what's called a VAF, and that's a variant allele frequency. And the cutoff point is that if you had 2.5% or greater, that they felt that that was equivalent to about 5% of your bone marrow cells having evidence of minimal residual disease. And so on the left-hand side is event-free survival, and the orange is the minimal residual disease line. And overall survival, likewise, the orange. So by all of these different types, whether it's flow cytometry, next generation sequencing, PCR, these again are retrospective analyses, but they all suggest that having minimal residual disease is an independent, poor prognostic factor for patients who are in a morphologic clinical remission. Now this is the bad news for transplanters. Well, really it's bad news for patients. Really bad, I'm sorry, it's not about me. It's about the patient. Don't cut that portion too. So that this study published last year, and what I can tell you is that yellow is if you have morphologic evidence of disease, active disease. The gray is if you are in remission, but there's evidence of minimal residual disease. And the blue is if you're in remission, but you don't have MRD. And so whether or not it's survival, which is much better, or relapse being much less if you do not have MRD, what's really worrisome, the take-home point is on the right-hand side, that if you have MRD positivity, it's associated with worse survival, higher relapse, and this is before you go to myeloablative allogeneic transplant. So big doses of chemotherapy and radiation can't overcome it. In fact, it's the same as the gray line. And gray line is if you can actually see bad blasts. Morphologically, you can see that that patient still has disease. So transplantation can't overcome that. And so it begs the question, then what do you do? So you have patients that have adverse features that you've been telling that the best thing to do is to go ahead with a transplant in first remission. Now you're explaining to your patient that it looks like they're in remission, but when you do this really detailed testing, they still have a little bit of disease, and you're trying to decide, do you go on now to transplant or do you not? So Craig, what would you do with this patient, do you think, that has, by what we currently know, still some disease?
Yeah, I mean, this is certainly a very challenging issue that is not at all uncommon to have this situation where somebody's
it looks good.
All the classical senses, but the more we learn about having any residual disease is unfavorable, and as these tools become available and are now being used in clinical practice, I would say if there are feasible approaches to try to eradicate that minimal residual disease, that's generally the route that we take. However, that being said, there are people who go to transplant with MRD, and certainly we know that their risk of relapse and a worse outcome is real.
So that's always the issue. Do you keep treating to try to get to MRD, or they're going to have a complication for which they don't get to transplant? But I think this data really worried transplanters and physicians that care for patients who look like, by all standards, that they're feeling well, their counts recover, they look like they're in remission, and now you got a little bit of something on that flow cytometry. What do you do? And so we really don't know right now, and it's a really moving landscape as well. It's
clinical trials.
Clinical trials, that's what clinical trials are preferred in this setting. Emerging therapies, is there something novel that you can do for this patient? Because if you can get them to an MRD negative status, we hope, you just saw those outcomes are so much better if they're in negative minimal residual disease. So that's kind of the take-home message from here. To be aware of the different ways that are being tested. We need prospective trials. This is all retrospective data. And we all know that retrospective data is fraught with concerns. So keep your eyes out for it and to be aware of it. Any other comments? I've talked a lot.
So you've had your allo transplant, things are looking good, not too much GVHD, but you still have MRD in the patient after an allo transplant. You give a donor lymphocyte infusion or something like that?
Yeah, that's a really good question. So there are clinical trials ongoing right now, even whether or not they had MRD heading into transplant or they didn't, and you're finding it post-transplant, is to do interventions with donor lymphocyte infusions. We have clinical trials ongoing right now.
The MRD positivity.
Yes, people are doing that. We're seeing it both in ALL, of which we know that donor lymphocyte infusions don't work, that work a little bit better, but we're also seeing them in ANL. So we have several trials ongoing right now through the NMDP.
Does the GVHD influence timing on the donor lymphocyte?
So we typically do not recommend donor lymphocyte infusions if a patient has active graft versus host disease.
Acute?
Either. Yep. Just because the risk of them dying of a graft versus host disease is much higher. So that's typically, and I think the other thing is to think about the targeted therapies, certainly for patients. We're hoping to have more, but yeah, it's tough. So I'm supposed to let you go now. I've already been given the hallway sign twice. And so thank you for coming. And you're supposed to fill out your form. You're all now well trained, it looks like, to fill out your form. We're going to be serving lunch for the next half hour, and there will be some 10-minute tours if you want to run up and see the rest of the building. And then we'll do the small group this afternoon. So I hope you enjoyed so far your morning. We appreciate you coming.